Chairman, we are ready to begin.
Thank you, DeLauren, and good morning. You look a little lonely sitting there this morning.
Yeah.
If you will conduct the roll call of our board members, please.
Yes, Chairman. I will begin with Roger Folsom,
Here.
Tommy Hopkins,
Here.
Kathleen Ruth,
Here.
Norman Boyd, Robert Coles,
Here.
David Cruz,
Here.
Shane Mobley,
Here.
Cynthia Rucker,
Here.
Anthony Williamson.
Here.
Chairman, that completes my roll call.
Thank you, DeLauren. We certainly have a quorum. We appreciate everyone's time this morning. And with that, the minutes were sent to you previously, and we'll ask Dr. Kathleen Ruth, Board Secretary, if she's had a chance to review those minutes, and if so, would she make a motion for approval?
I have, Mr. Chairman, and motion to approve.
I have a motion for approval. Do we hear a second?
Second.
I have a second. Any further discussion, additions, or corrections? Hearing none, all those in favor of the motion signify by aye.
Aye.
Opposed, no. Motion carries and the minutes are approved. Hope everyone had a cool and joyous Independence Day. You had to work at it if you were cool, I assure you. But 250th birthday of this country, that's pretty awesome. It's hard to believe we're in the middle of summer, but here we are. Today in front of us, we have somewhat of a robust agenda, and we will begin to move forward with that. And we'll ask Commissioner Burke for his report at this time. Commissioner.
Thank you, Mr. Chairman and members of the board, and of course our staff and anybody in the general public that's listening to us today. We appreciate your being here. I am off site from the department. Several of our leadership are meeting with hospitals on some of our ongoing programs, and great dialogue going on here with those folks, and we're all learning from each other. So I'll kick off with our update for you guys. Of course, one of our biggest projects is the Rural Health Transformation Program. That's part of why we're here today meeting with the hospitals about what's going on. We are on target to get money out the door. We've got several rounds of funding opportunities. I won't go into details on those because they are available on our website, and it would take too long to go into all of them, but just know that we are opening up funding opportunities for the different programs that we had lined up for this first year of funding. And as far as we can tell, all our systems are working, and we should be meeting our internal deadlines to make sure those funds get to where they're supposed to on time. We did have, as part of the Rural Health Transformation program, we did have CMS leadership come down. They did a site visit to evaluate what we're doing. We did take them, not all over the state, but they got a taste of how big and broad Georgia is. So we went to Morgan Medical Center, Jasper Memorial Hospital, and the University of Georgia to get presentations on different aspects of what we're implementing this first year. And we got great feedback from the leadership in CMS that Georgia's going in the right direction and is actually leading the country in a lot of the aspects of our getting our infrastructure in place and our grant programs in place and getting money out the door. So staff was very excited to get positive feedback. And of course, they had suggestions for things we could do better. And we certainly are always trying to improve our processes and policies. As part of HR1, which is where the Rural Health Transformation Project was born, HR1 also was the national community engagement requirements that was put in place by the federal government for Medicaid that does affect our what we we're calling pathways, will continue to call pathways, but it is morphing into this national community engagement requirement that Stuart Portman, our Medicaid director, will be going over with you guys later on. So I won't go into details with that, but just know that we're following and doing what the federal government is asking us to do from the standpoint of standardizing those community engagement requirements across the country. Another important issue, especially for the hospitals that we're working with, is the directed payment program. As we talked about last month, the directed payment program updates and what they call preprints have been submitted to CMS. CMS has asked a series of questions, as they always do, to clarify, and those questions have been answered by the department. Last year, it was a long wait to get those approved. We're crossing our fingers that because of the work that's been done and our relationship with CMS, that this year's preprints will be approved in a little more of a timely manner, but we stand ready to answer any further questions that CMS has, and hopefully we'll have news on that sometime in the next couple of months. Another big issue that's important for a lot of reasons is what we call revalidation. Now, that's where we clarify that a provider that's on our Medicaid program that is a Medicaid provider provides updated information on their licensure and their sites of service so that we can ensure that for anti-fraud reasons that the people that are on the Medicaid program are doing the work that they're supposed to do. And it also is part of our ability to define what an adequate network is. You know, providers frequently open offices in new places, but they also close offices. And we are trying to make sure that the information we have available to the public, and of course for our own internal use, is the most accurate. That does require some work on the part of the providers to make sure they fill out the appropriate updated information. And we're working with vendors such as the CAQH and our care management organizations to try to make that as easy as possible on the providers. But it's an important issue for us. It also is important to our federal partners from the standpoint of the fraud, waste, and abuse issues that have been so prevalent in the news recently. So just know that that's something that will be happening in the next couple of months. And if you hear of any issues related to that, just make sure you bring it to our attention. And the last update is on the fraud subject in particular. We did have a release for information or request for information in partnership with the Department of Administrative Services to get updated information from any vendors on ways that we could actually improve our program integrity and to protect this taxpayer dollars. I think we have a robust program in place, but there's new technology and opportunities that come out frequently in this space. And so we have closed that RFI. We got 39 vendors who have given us ideas and recommendations, and we'll be working through those. And Georgia State University is helping us with evaluating those vendor responses. And hopefully sometime this fall, we'll have an evaluation if there's anything that we think we need to add to what we're doing already in that space. Sorry for the long-winded update, Mr. Chairman, but we've been busy. And a lot going on at the department, and certainly we appreciate everyone's grace if we're not as responsive as they think we should be, because all of our folks are wearing multiple hats and are working really, really hard. And I want to thank them for all the dedication that they put into their job every day to make Georgia healthier. With that, I'll be glad to stand for questions, or I'll move into our employee milestones.
Any questions from board members of the commissioner?
Yeah, this is Tommy. Where are we and what are we doing as far as, our discussions previously on GME funding with some of this money? What's the latest on that, please?
The part of the DPP program requires healthcare care workforce investment of the facilities. And the new DPP that was just approved last year requires us to come up with a program of requirements and incentives and standards, goals, however you want to put it. And we're internally working on that issue to determine what the appropriate way to get to that. It's a little bit difficult, more difficult than it might seem on the surface, because all of the different providers are kind of in a different place when it comes to GME. You have some that are doing all they possibly can, and others that can't do more because of their nature of the institution and their ability to do increased teaching. So it's not like it's a homogeneous group that we can just set one standard for all of the facilities that are doing graduate medical education. It requires a very, very in-depth assessment to see who has more capacity and where we can grow the capacity and where there are opportunities, especially the rural areas of the state, which ones actually can do GME and which ones just would never be able to do it no matter what resources we poured into them. So we're working on internally a program for that, and then we'll be, once we feel like it's in a good spot, we'll be sharing it with all the stakeholders and be moving forward. So we'll get out more information soon. The legislature did provide some GME supports and pending evaluation by CMS, and we also have some GME in the Rural Health Transformation Fund. I don't have the numbers in front of me, but I know we did some funding opportunities earlier this year that were new and different, and have some more of that in the pipeline. That work is being done by the healthcare workforce folks. That's kind of their role in this as far as workforce development in healthcare. We'll be partnering with them as well.
In your meetings with the hospitals, has this come up? The recent meetings that you're describing with the various hospitals, does it come up?
Oh yeah, we're having a lot of conversations about that with, what I would call sidebar conversations about what's going forward. This is one of those things that everybody's going to have to get on the same page. We've got to have a united front, whether that's leadership in the agency, but also very importantly with the legislature and governor's office and the folks that actually do the training on the ground. I mean, everybody's got to have a seat at the table, and we got to come up with a program that works for everybody. And I wish I could say that was easy to do, but it's certainly worthwhile work and is desperately needed for Georgia.
Thank you.
Any additional questions for the commissioner from board members?
Yeah, Mr. Chairman, this is Shane Mobley. I wanted to know on the revalidation part of Medicaid, do we have anything in place now or maybe in the future whereby if you're going to participate in the Medicaid program, you have to have a brick and mortar location for certain specialties or anything like that? I know psych a lot of times does a lot of stuff on telemed, but I was just curious about that.
I don't know off the top of my head, Shane. I will be glad to get with our staff and see where we are on that issue. It's one of those, there's a lot of issues that are in state law about, what we can do and can't do when it comes to providing remote services in healthcare. CMS has guidance and requirements along with state law. So I don't know that, again, that's a very complex question, but I'll be glad to take it back to staff and get back with you guys on it.
Okay, yeah, I appreciate that, because I know a lot of people that may just shut down the brick and mortar and just go straight telemed, and no one really knows about it. So,
Yeah.
I'm very happy and commend you guys for doing the revalidation. I think that's really great for
Yeah.
everyone.
That's the first step, and it's super important with our national partners that the people that say they're providing Medicaid services in Georgia and are billing us and the federal government for it are actually doing the work, and in a quality fashion. So we take that very, very seriously, and we're one of the states that CMS has actually identified that has been aggressive and uh, uh, providing criminal prosecution for people that do get caught with Medicaid fraud, but the criminal element is always thinking of other ways to get money illegally, and we have to kind of stay on top of it. So we want to make sure we're continuing to mature as and being as aggressive as we can to make sure that people that are providing services in Georgia are doing it in a quality manner, and in a way that is legal under state law. So,
Any additional questions for the commissioner?
well, I'm going to go ahead with the milestones, Mr.
Okay.
Chairman. Want to recognize at 35 years, Brenda Mixon, who works at the Medical Assistance Plan. Marilyn Jones at 15 years in the Office of Inspector General. Susan Gustiani, 15 years in Medical Assistance Plans. Stacy Hillock, 15 years in Commissioner's Office. Connie Engel, 15 years at the Georgia Board of Dentistry. 10 years is Marie Celine Williams at the Office of Inspector General. Robbie Dunbar and Health Facility Regulation. At 5 years, Deborah Troy Center, Financial Management. 5 years, Stacy Altman, Board of Dentistry. And at 1 year, we have Kimberly Bolding and Medical Assistant Plan. We have Chase Ian Fan and CMO Performance Management. Lance Sidney Home and Medical Assistance Plan. And Victoria No in CMO Performance Management. I want to thank all those employees for their dedication, and I thank their division and staff people that they work for, because obviously they're doing a good job to be able to retain these folks for so long. So that's our employee milestones, Mr. Chairman, and I'll turn the agenda back over to you.
Thank you, Commissioner. We certainly echo our appreciation and congratulations to each one of those celebrating a milestone. We thank everyone for their work on behalf of the department. We'll move into our working agenda now. And first item will be the clarification of language for reimbursement for outpatient clinical diagnostic laboratory services. And we'll be considering this for final adoption, and be presented to us by Lisa Davies, Chief Operating Officer of Medical Assistance Plans. Good morning, Lisa.
Good morning. Thank you, Chairman Folsom, Commissioner Burke, and members of the board. My name is Lisa Davies, and I serve as the Chief Operating Officer of the Medical Assistant Plans here at the Department of Community Health. Today, I'm presenting to you a state plan amendment to clarify the language for reimbursement of outpatient clinical diagnostic laboratory services. The department seeks your favorable consideration for final adoption, retroactive to June 12th, 2026, pending CMS and board final approval. As directed by the U.S. Department of Health and Human Services in response to an audit, the state plan will be updated to amend the language on reimbursement for outpatient clinical diagnostic laboratory services. These services will be reimbursed at 80% of the Medicare Lab CAHBA or Medicare Clinical Lab Fee Schedule rate. This clarification is intended to ensure consistency, transparency, and alignment with established reimbursement methodologies. This change will result in savings of approximately $200,000 in state funds and $400,000 in federal funds, for a total savings of approximately $600,000. A public hearing was held on June 17th, 2026 at 10:30 a.m. via Zoom, and written comments were accepted through June 24th, 2026. The department received one comment from Ms. Flannery at Quest Diagnostics. Quest Diagnostics requested DCH resolve ambiguity around the term actual charge and ensure consistency across Medicaid manuals and the state plan. The department thanks Quest for their comment and will work to ensure terminology is aligned across all documents upon approval. This morning, I'm requesting the board's final adoption of the state plan amendment to clarify the language for reimbursement of outpatient clinical diagnostic laboratory services retroactive to June 12, 2026. I am happy to answer any questions you may have.
Any questions for Lisa from board members? Hearing none, is there a motion for final adoption?
Hopkins, so moved.
Dr. Tommy Hopkins has made a motion for final adoption. Is there a second?
Second.
Shane Mobley.
Shane Mobley has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
Aye.
Any opposed, no. Anyone abstaining? Motion carries. Lisa, you're also presenting your second item, which would be the clarification of language for reimbursement for independent laboratory services.
Yes, thank you, Chairman Folsom. The next item I bring to the board today is a state plan amendment to clarify the language for reimbursement of independent laboratory services. The department seeks your favorable consideration for final adoption retroactive to June 12, 2026, pending CMS and board final approval. Once again, as directed by the U.S. Department of Health and Human Services in response to an audit, the state plan will be updated to amend the language on reimbursement for independent laboratory services. These services will be reimbursed at 80% of the Medicare Lab, CAHBA, or Medicare Clinical Lab Fee Schedule rate. This clarification is intended to ensure consistency, transparency, and alignment with established reimbursement methodologies. This change will result in savings of approximately $1.2 million in state funds, $2.4 million in federal funds, for a total of $3.6 million in total savings. A public hearing was held on June 17, 2026 at 11:30 a.m. via Zoom audio, and written comments were accepted through June 24, 2026. The department received no comments. So this morning, I'm requesting the board's final adoption of the state plan amendment to clarify the language for reimbursement of independent laboratory services, retroactive to June 12, 2026. I am happy to answer any questions you may have.
Any questions from board members? Hearing none, all those in favor of is there a motion for final adoption? Getting a little ahead of myself.
Motion, Cynthia Rucker.
Cynthia Rucker has made a motion for final adoption. Is there a second?
Dr. Coles, second.
Dr. Coles has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Opposed, no. Anyone abstaining? Motion carries. Lisa, thank you for your presentations this morning.
Thank you.
Next item on the agenda is the Children's Health Insurance Program Health Services Initiative, and this will be presented to us by our Chief Operating Officer, Joe Hood. Good morning, Joe.
Good morning. Thank you, Mr. Chairman. Good morning, Mr. Chairman, Commissioner, and board members. My name again is Joe Hood, and I'm the Chief Operating Officer for the department here at the Georgia Department of Community Health. Today, I'm presenting for final adoption a Children's Health Insurance Program Health Services Initiative, or HSI, for final adoption consideration. Upon CMS approval, this change will provide a statewide developed assessment for strengths and needs of children at risk as they appear for various reasons before a juvenile court at a cost of $26.8 million annually, with an applicable planning cost to date of $183,976 for this first phase. The proposal provides for early and periodic diagnostic and treatment services known as EPSDT, such as physical, vision, and hearing exams, and any recommended behavioral services such as multisystemic therapy or other similar services as directed by the assessment and ordered by the court. The Health Services Initiative satisfies two CMS mandates. The first is Justice Involved Youth, which requires an assessment and treatment and case tracking. And secondly, the EPSDT CMS mandates within our Medicaid policy and procedure. The services will be phased in, utilizing grants to each of the following juvenile courts through the Criminal Justice Coordinating Council in the Cobb, Douglas, and Middle Judicial Circuits. The HSI will be in conjunction with the delivery of the Department's State Planning Grant for Justice Involved Youth due to the overlapping nature of the mandate and this initiative. A public comment hearing was held, but only written comments were received, and I would like to share the 5 summaries of those comments individually, given that each of them are from state organizations. The first is from Jessica Pennington, who is the Children in Need of Services Program Director on behalf of the Council of Juvenile Court Judges. She commented, the proposed change to establish a health services initiative for children and youth who interact with the courts will have an enormous impact across the state of Georgia by implementing a uniform statewide assessment tool and providing assistance for health-related services that are tailored to Georgians' children and youth health needs. She further commented, in her work, she oversees statewide initiatives to the children in need population, and that there currently is not a standard assessment tool, and this proposal will reach thousands of children and youth across Georgia that otherwise would go with unmet needs. The second commenter is from Judge Thomas Cole, the presiding juvenile court judge in Savannah, who also serves as the chair of the Georgia Council of Accountability Court Judges and as vice president of the Georgia Council of Juvenile Court Judges. Judge Cole stated, as a juvenile court judge, and in my various statewide roles, I'm keenly aware of the significant impact that this type of assessment and intervention can have. It is the mission of all of these organizations to improve the outcomes in our justice system for Georgia's youth and families. Critical components are the administrative and operational support for juvenile courts that this provides. By amending the state plan to allow these services, we as a state can ensure the most needed and appropriate services are rendered to children and youth. The third commenter is Melissa Carter, as the director and on behalf of Emory's Barton Child Law and Policy Center. She comments, through the center's clinics, they see the children in court-involved proceedings face a heightened risk of poor health outcomes driven by trauma, unstable environments, and lack of access to early behavioral support. This amendment addresses the gap directly. A uniform statewide assessment tool will give judges, court staff, and service providers a shared, structured understanding of each child's needs and strengths, supporting individualized service planning rather than the one-size-fits-all disposition that is there currently. The fourth commenter is from our partners at the Department of Juvenile Justice, the Deputy Commissioner Lisa Mance. She comments, as the agency primarily responsible for the care, supervision, and rehabilitation of justice-involved youth in Georgia, we recognize that this initiative as a transformative step toward addressing deep-seated behavioral health and trauma-informed needs of the youth we serve is needed. Furthermore, the HSI directly aligns with and enhances our current agency efforts to meet federally reentry, screening, and continuity of care framework mandates. The fifth and final commenter is from Director Judy Fitzgerald on behalf of the Georgia Voices for Children. She comments, among the children Voices serves, children who come before the courts as children in need of services are some of the most vulnerable in our state. For these children, early and accurate identification of behavioral health needs is foundational to fair outcomes and to the interrupting deeper system involvement for the children. The department appreciates the strong support from so many statewide stakeholder organizations who have written in support of this CHIP HSI state plan amendment that is under consideration for final adoption. Mr. Chairman, that concludes my presentation, and if there are no further questions, I would ask for favorable adoption.
Any questions from board members? Hearing none, is there a motion for final adoption?
So moved, Kathleen Ruth.
Kathleen Ruth has made a motion for final adoption. Is there a second?
Second, David Cruz.
David Cruz has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Opposed, no. Anyone abstaining? Motion carries. Joe, we'll move to your second item, which is a modification to Rural Hospital Newborn Delivery Program public notice.
Thank you, Mr. Chairman. My next presentation is final adoption consideration of a modification proposal for a state plan amendment titled Modification to Rural Hospital Newborn Delivery Program. Pursuant to House Bill 947, line item 126, passed during the 2026 legislative session and pending approval by the Centers of Medicare and Medicaid Services in the Department of Community Health, we propose to modify the Medicaid state plan by discontinuing the designation for the Rural Hospital Newborn Delivery Program for hospitals with a population in the county between 35,001 and 50,000. This will discontinue the payment of $1,500 per newborn delivery currently in place in those counties. However, the newborn delivery payment for hospitals in counties less than 35,000 will remain. This is effective July 1st, 2026, consistent and concurrent with the state fiscal year appropriation in which it was passed. The fiscal impact is a reduction in total fund expenses of $6.4 million. A public comment hearing was held. There were no public comments. Additionally, written comments were available for receipt. However, no written comments were received as well. Therefore, Mr. Chairman, I would ask for favorable consideration and final adoption of this proposed change.
Any questions from board members? Hearing none.
One
Go ahead.
question, Chairman. Thank you, Joe. Mr. Hood, can you tell me how many rural organizations will be impacted by this?
I would have to take that back and follow up with you. I apologize. I don't know that offhand. This has only been in place for 1 year, so we would have to look and see to what extent that we've had utilization.
Okay.
I'm happy to do that.
Okay.
Any additional questions for Joe? Hearing none, is there a motion for final adoption?
Hopkins, so move.
Tommy Hopkins has made a motion for final adoption. Is there a second?
Shane Mobley seconds.
Shane Mobley has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Any opposed, no. Anyone abstaining? Motion carries. Joe, thank you for your presentations this morning.
Thank you, Mr. Chairman.
Next item on our agenda is rules and regulations for adult daycare centers, and we'll be considering that for final adoption. And Patrick Long, Associate General Counsel, will be presenting to us. Good morning, Patrick.
Good morning, Chairman Folsom, Commissioner Burke, and members of the board. The Division of Healthcare Facility Regulation presents rules today for final adoption for adult day centers. These rules are found in Chapter 111-8-1 of the Department's Rules and Regulations. These rules were previously brought before the board for initial adoption on May 14th, 2026 meeting. These rule revisions address two issues. First, the changes add a cross-reference to the existing rules and regulations for criminal background checks found in Chapter 111-8-12, so that all requirements associated with criminal background checks for owners, administrators, and direct care staff are contained within those designated rules. There's no substantive changes being made to these requirements. The second change is to update requirements for health screenings for adult day center employees, including screening for tuberculosis. The revised TB language aligns with the recommendations for the Centers for Disease Control and Prevention. A public comment hearing was held via Zoom on June 16th, 2026 at 1 p.m. Written comments were due on or before June 18th, 2026 at 5 p.m. The department received 2 written comments and no oral comments. A summary of the public comments received is one commenter expressed a concern that the proposed rule change was vague. The commenter noted that they currently screen for tuberculosis and other communicable diseases, along with providing training and are concerned that the rule change will inhibit their ability to quickly hire and onboard new staff. And the second commenter questioned whether the rules would require registered nurses to be subject to the CDC. The department's response for these comments, the department would like to thank both commenters for their written comments. The revised rules are designed to be less burdensome for the centers by removing the requirement for staff to have a complete physical examination prior to employment. The rule imposes CDC guidance as a minimum standard, allowing centers the flexibility to design a screening program that will appropriately address health and safety risks. Most centers are already have a screening program in place that will meet these requirements. For centers that operate in multiple states, the use of CDC guidance as a baseline standard is also going to be helpful in reducing the customization of facility policies that is necessary when the state licensing rules differ from the federal guidelines. These rules do not change the oversight of registered nurses in Georgia, which is the responsibility of the Georgia Board of Nursing. At this time, the department would respectfully request consideration today for final adoption of these rule changes, and I'm happy to answer any questions.
Any questions from board members? Hearing none, is there a motion for final adoption?
Motion for final adoption, David Cruz.
David Cruz has made a motion for final adoption. Is there a second?
Dr. Coles, second.
Dr. Bob Coles has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
Aye.
Any opposed, no. Anyone abstaining? Motion carries. Patrick, we'll move to your second item, which is rules and regulations for private home care providers.
Thank you, Chairman. The Division of Healthcare Facility Regulation presents rules today for final adoption for private home care providers. These rules are found in Chapter 111-8-65 of the department's rules and regulations. These rules were brought before the board originally as well for initial adoption on the May 14th meeting. And these rule revisions are substantially similar to the Adult Day Center rule revisions. A public comment hearing was held via Zoom on June 16th, 2026 at 11:30 a.m. and written comments were due on or before June 18th, 2026 at 5 p.m. The department received 6 written comments and no oral comments. 2 of the comments that the department received were the same comments that were received for Adult Day Center, and the emails just had both rules listed on the title of the email. For the remaining comments, a summary of those is as follows. One commenter wrote in support of the proposed rule change, stating that they are reasonable measures to protect vulnerable patients and align with current practices. 2 commenters sent questions about the parameters of the health screening program requirements, including whether internal screening or assessment would be satisfactory in lieu of a physician-signed physical examination, and whether screening must include tuberculosis, hepatitis, and influenza. They also asked for examples to be provided by the department. And then the other commenter asked whether the health screenings could be conducted by a registered nurse or a licensed practical nurse. The department thanks all commenters for their written comments. Regarding the parameters of the health screening program requirements, the health screening can be satisfied through internal screening or assessment and does not require a physician-signed physical examination. The rule does impose CDC guidance as a minimum standard, allowing providers greater flexibility to design programs that meet the specific facility's needs. And again, most providers would have screening programs in place that already meet these requirements. And we do feel it would be beneficial for providers who operate on a national scale to have CDC guidance as a baseline. The department does not currently have examples of a compliant program policy, and both registered nurses and licensed practical nurses may perform initial health screenings. However, the results of the initial baseline screening may require further review of an RN or physician. These rules do not change the oversight of RNs and LPNs in Georgia, which is the responsibility of the Georgia Board of Nursing. At this time, the department would respectfully request final adoption be considered today for these rule changes, and I'm happy to answer any questions.
Any questions from board members? Hearing none, is there a motion for final adoption?
Shane Mobley
So
motions.
moved.
Shane Mobley has made a motion for final adoption. Is there a second?
Hopkins a second.
Tommy Hopkins has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Any opposed, no. Anyone abstaining? Motion carries. Patrick, we're giving you quite a workout here. We're going to move you to the third item, which is rules and regulations for personal care homes. And this will be for initial adoption.
Yes, thank you, Chairman. The Division of Healthcare Facility Regulation presents the rules today for initial adoption for personal care homes. These rules are found in Chapter 111-8-62 of the Department's Rules and Regulations. These rule revisions address two issues. First, the changes will update the requirements for health screenings for personal care home employees, including the screening for tuberculosis. The revised tuberculosis language would align with the recommendations for the Centers for Disease Control and Prevention. The second change is to align with the authorized tasks for certified medication aids to include GLP-1 medications in compliance with House Bill 659 from the 2026 session of the General Assembly. These revised rules will streamline the documentation requirements for employee health screenings. The health screening requirements are substantially similar to current standards. Additionally, aligning with CDC requirements will benefit providers operating on a national footprint. The changes associated with House Bill 659 are mandated by law, and expanding the authorized tasks for CMAs will reduce the workload for licensed staff, resulting in potential cost savings for the facility. Accordingly, the department does not anticipate a negative economic impact on personal care homes. A public comment hearing is to be held via Zoom on August 11th, 2026 at 11 a.m. And written comments will be due on or before August 13th, 2026 at 5 p.m. And at this time, the department respectfully requests for consideration today for initial adoption of these rules, and I'm happy to answer any questions.
Any questions from board members? Hearing none, is there a motion for initial adoption?
Motion for initial adoption, David Cruz.
David Cruz has made a motion for initial adoption. Is there a second?
Second, Dr. Coles.
Dr. Coles has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
Aye.
Any opposed, no. Anyone abstaining? Motion carries. Patrick, we'll move to your next item, which are rules and regulations for assisted living communities.
Thank you again, Chairman. The Division of Healthcare Facility Regulation presents rules today for initial adoption for assisted living communities. These rules are found in Chapter 111-8-63 of the Department's Rules and Regulations. These rule revisions and anticipated economic impact are substantially similar to those for personal care homes. A public comment hearing is to be held via Zoom on August 11th, 2026 at 2 p.m. Written comments will be due on or before August 13th, 2026 at 5 p.m. And at this time, the department would respectfully request for consideration today for initial adoption of these rule changes, and I'm happy to answer any questions.
Any questions from board members? Hearing none, is there a motion for initial adoption?
Hopkins so moved.
Tommy Hopkins has made a motion for initial adoption. Is there a second?
Dr. Coles, second.
Dr. Coles has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Any opposed, no. Anyone abstaining? Motion carries. Next item, Patrick, is rules and regulations for birth centers.
Thank you, Chairman Folsom. The Division of Healthcare Facility Regulation presents rules today for initial adoption for birth centers. These rules are found in Chapter 111-8-7 of the Department's Rules and Regulations. These rule revisions are to align with the Department of Public Health's rule found in Georgia Rules and Regulations 511-5-5 for testing for inherited disorders in the newborn, which provide for additional newborn screening types. These revised rules will amend the department's rule to expand health screening types for newborns, which will allow birth centers greater discretion in determining appropriate screening types for newborns as promulgated in the DPH rules. No negative impact is anticipated by the department. A public comment hearing is to be held via Zoom on August 12th, 2026 at 11:30 a.m. Written comments will be due on or before August 14th, 2026 at 5 p.m. And at this time, the department respectfully requests consideration today for initial adoption of these rule changes, and I'm happy to answer any questions.
Any questions from board members? Hearing none, is there a motion for initial adoption?
So moved, Cynthia Rucker.
Cynthia Rucker has made a motion for initial adoption. Is there a second?
Second, Kathleen Ruth.
Kathleen Ruth has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Any opposed, no. Anyone abstaining? Motion carries. Thank you. Patrick, thank you for all your presentations this morning.
Thank you.
Next item on the agenda is an informational update, Certificate of Need Technical Advisory Committee update. Rebecca Goldman, Planning and Research Analyst, will present this to us. Good morning.
Good morning, Chairman Folsom, Commissioner Burke, and members of the board. For the Office of Health Planning, I will be presenting an update on the Technical Advisory Committees for Certificate of Need. Pursuant to OCGA Section 31-6-21A, the Georgia Department of Community Health is required to review and update the Certificate of Need State Health Plan every 5 years, beginning in 2025. The CON's State Health Plan defines the need methodologies, the standards, and rationale used to evaluate projects involving facilities and services requiring a CON. In accordance with OCGA sections 31-6-21C and 50-4-4, the commissioner may establish technical advisory committees in consultation with the board to inform effective strategy development and execution. So for 2026, DCA is establishing technical advisory committees to review the following CON rules for positron emission tomography units, megavoltage radiation therapy units and services, ambulatory surgery services, and specialized cardiovascular services, which include adult cardiac catheterization services, adult open heart surgery services, and pediatric cardiac catheterization and open heart surgery. Each committee will evaluate financial access, the geographic availability of services, and other factors to recommend rule updates. Any proposed rule changes resulting from the recommendations of the committees will be brought before the board for review and approval. We've included the list of members of each of the committees that's been provided to board members in your packet, and it will be available at the department's website. Let me know if you have any questions.
Any questions from board members? Well, there's no action to be taken here, so if there are no questions, thank you for your presentation.
Thank you.
The next item on our agenda is from the Medical Assistance Plans, a state plan amendment, Medicaid community engagement requirements for certain adults. And Stuart Portman, our Executive Director of Medical Assistance Plans, will present to us. Stuart, good morning.
Good morning, and thank you, Chairman Folsom, Commissioner Burke, and members of the board. My name is Stuart Portman, and I serve as Executive Director of the Medical Assistance Plans Division here at the Department of Community Health. Today, I am presenting to you the public notice to align coverage for eligible adult populations currently covered by the state's Pathways to Coverage 1115 demonstration waiver program, with federal statute and CMS regulations and guidance. The department seeks your favorable consideration for initial adoption, pending final board and CMS approval. The Department of Community Health will submit updates to Georgia's Medicaid state plan to include provisions mandating certain enrolled Medicaid beneficiaries and certain applicants to comply with the newly established community engagement requirements in the Working Families Tax Cut Act, or WFTC. Section 1902XX of the WFTC legislation establishes a minimum 80-hour per month community engagement requirement for applicable individuals ages 19 to 64 applying for or enrolled in Medicaid. This new requirement is intended to empower Medicaid beneficiaries through employment, education, or volunteer service, thereby helping the individual to achieve self-sufficiency and independence. Applicable individuals must meet the community engagement requirements at application, renewal, and during various periods of enrollment. DCH has implemented procedures to ensure these requirements are verified using reliable information available to the state and will revise its processes to incorporate all exceptions identified herein. Individuals who do not comply with the minimum 80-hour per month community engagement requirement will be disenrolled from or denied Medicaid eligibility. Individuals may reapply at any time. Currently, Georgia has an 1115 demonstration waiver called Georgia's Pathways to Coverage, often referred to as Pathways, that has similar community engagement requirements. The Pathways waiver will be amended in January 2027 to comply with the new WFTC provisions. In practice, this means the Pathways to Coverage 1115 demonstration waiver will be renewed to only allow Georgia to apply the community engagement requirement to those under 100% of the federal poverty level. There is a statutory prohibition on waiving any other part of the community engagement requirement as outlined in the WFTC. Additional information will be provided in subsequent public notices. The WFTC defines the applicable individuals that must meet the minimum 80-hour monthly community engagement requirement. An applicable individual is defined as follows. 1, age 19 to 64. 2, income at or below 100% of the federal poverty level for individuals enrolled in Georgia's Pathways to Coverage 1115 demonstration waiver. 3, eligible for or enrolled under the state plan adult group or otherwise eligible for or enrolled in the Pathways to Coverage 1115 demonstration waiver category of eligibility. 4, not pregnant. 5, not enrolled in Medicare Part A or Part B. And 6, not otherwise eligible for or enrolled in a mandatory or optional coverage group under the state's Medicaid state plan. Applicable individuals are required to demonstrate, as a condition of their eligibility, a minimum of 80 hours per month of community engagement activities for 1 month preceding their Medicaid application and during their Medicaid enrollment. Individuals may combine the community engagement activities to meet the 80-hour per month requirement. An applicable individual demonstrates community engagement for a month if the individual meets one or more of the following conditions for such month. 1, works not less than 80 hours. 2, completes not less than 80 hours of community service. 3, participates in a work program for not less than 80 hours. 4, is enrolled in an educational program at least half-time. 5, engages in any combination of the allowable community engagement activities listed in this public notice document for a total of not less than 80 hours per month. 6, has a monthly income that is not less than the applicable minimum wage requirement under Section 6 of the Fair Labor Standards Act of 1938, the federal minimum wage, multiplied by 80 hours. And 7, the applicable individual is a seasonal worker and has an average monthly income over the preceding 6 months that is not less than the applicable federal minimum wage requirements under Section 6 of the Fair Labor Standards Act of 1938, multiplied by 80 hours. The public notice contains definitions for the categories requiring further detail, and we encourage folks to take a look. DCH and its partners will verify compliance with the community engagement requirement. Individuals who are unable to demonstrate compliance will receive notice of noncompliance. This notice of noncompliance provides the applicant or beneficiary with 30 calendar days from the date of issuance to demonstrate compliance or to provide documentation showing the requirement does not apply. Importantly, in order to comply with federal law and regulation, Georgia is mandated to cover individuals under 100% of the federal poverty level, meeting the definition of a mandatory exception or mandatory exclusion. This is a population that is not covered today. First, I will outline the exceptions. The WFTC legislation established mandatory exceptions from completing the community engagement requirement for certain applicable individuals if for part or all of a month, the individual is 1, under the age of 19, 2, entitled to or enrolled in Medicare Part A or Medicare Part B, 3, described in any of the mandatory eligibility groups, 4, at any point during the 3-month period ending on the first day of that month, the individual was an inmate of a public institution, and 5, a specified excluded individual. Individuals in this category are deemed to be compliant with the community engagement requirement for the month in which their condition above exists. Next, I will outline the exclusions. The following list of individuals are excluded from the definition of an applicable individual as defined above, and therefore are not required to demonstrate compliance with the community engagement requirements to qualify for Medicaid. 1, American Indians and Alaska Natives. 2, former foster care youth. 3, inmates of a public institution. 4, medically frail individuals or individuals who otherwise have special medical needs that significantly impair their ability to comply with this requirement. 5, individuals that meet the TANF work requirements. 6, participants in a drug or alcohol rehabilitation or treatment program. 7, pregnant women or women in the postpartum period. 8, parents, guardians, caretaker relatives, or family caregivers of a dependent child 13 years of age and under, or a disabled individual. 9, veterans with a total disability rating. And 10, individuals subject to the work requirements under the Food and Nutrition Act of 2008. DCH or its designee may request sufficient supporting information, including documentation, when applicable, to verify an individual's status as an excluded individual. An individual who is medically frail or otherwise has a special medical need is defined as an individual whose physical, mental, or other behavioral health condition significantly impairs the individual's ability to comply with the community engagement requirement. This includes individuals who are blind or disabled as defined in Section 1614 of the Social Security Act, and individuals that have a substance use disorder, a disabling mental disorder, a physical, intellectual, or developmental disability that significantly impairs their ability to perform one or more activities of daily living, or a serious or complex medical condition. Individuals must meet one of these categories to qualify for the medically frail exclusion. In accordance with federal regulations, DCH has developed a list of health conditions and diagnoses to assist in identifying the individuals who meet the criteria for medical frailty. Attachment A to the public notice contains the list of health conditions and diagnoses that satisfy the criteria for medical frailty. Attachment B to the public notice contains a listing of conditions that may meet the criteria for medical frailty if combined with further information, be it codes, medical data reviews, or specific requests for additional information. DCH will develop a policy and process to determine if an individual is deemed medically frail based upon the health conditions listed in Attachment B. These health conditions and diagnoses include conditions related to substance use disorders, mental and behavioral health, significant intellectual disability, significant developmental disability, and significant physical disability, infectious and parasitic diseases, cancers, diseases of the blood, endocrine, nutritional, and metabolic disorders, diseases of the nervous system, diseases of the eye and nexa, circulatory, respiratory, digestive, skin, and musculoskeletal or connective tissue disorders, genitourinary conditions, congenital and chromosomal abnormalities, abnormal clinical and laboratory findings, injuries, and other relevant factors. The lists of health conditions in Attachment A and Attachment B to the public notice will be revised on an ongoing basis as appropriate to add or remove health conditions based upon DCH's experience applying this exclusion. DCH will develop a policy and process to request consideration in those instances where the individual's health condition is not on those lists. The fiscal impact for this community engagement requirement for state fiscal year 2027 will be as follows. The total amount of state funds will be $60,642,020. The total amount of federal funds will be $120,757,980. The combined total for state fiscal year 2027 is $181,400,000. A public notice hearing will be held on July 14th, 2026 at 11:30 a.m. via Zoom audio, and written comments will be accepted through July 21st, 2026. Today, I am requesting the board's initial adoption of the proposed changes to amend the Medicaid state plan to include provisions mandating certain enrolled Medicaid beneficiaries and certain applicants to comply with the newly established community engagement requirements. I'm happy to answer any questions you may have.
Any questions for Stuart from board members?
Yes, Stuart, Tommy, how do we confirm accurate reporting of their income levels below the poverty level?
So we have income verification as a part of our Medicaid review process today, and we're working to automate that in order to provide for a more streamlined approach given the potential for additional applicants. But we do income verification as a consistent part of our Medicaid eligibility processing today.
Do you review their tax returns, or are these people paying any taxes?
We do not have a process that relies on a form of attestation. So there is a lot of review based on any publicly available information that could include a variety of income sources. And then we can always seek additional information by direct request to an applicant or a current member.
Any additional questions for Stuart?
Stuart, how will they submit verification or documentation of their participation in community engagement activities?
So we have the plan would be for this to mirror at this point the process that would apply to any other eligibility category where the caseworker engagement from the Department of Human Services would engage with a verification follow-up checklist. And we would mirror that same process here. As it relates to any specific elements that are determined based on further guidance from CMS, we will be sure to incorporate that into the process. But the goal is to treat this population in the same way that we would treat any other eligibility category, just with some of the specific elements that are highlighted in the statutory requirement.
Thank you.
Any further questions for Stuart? If not, we'll entertain a motion for initial adoption.
Motion.
So moved, second, Kathleen Reed.
Who made the initial motion?
Williamson.
Anthony Williamson has made the motion for initial adoption. Kathleen Roof has seconded. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Opposed, no. Anyone abstaining? Motion carries. Stuart, thank you for that information this morning. We've covered a vast amount of information today and a number of items, and appreciate the board members' attention to this. Stuart, thank you.
Thank you.
Would there be any further new business that needs to come before the board this morning? Commissioner, do you have any additional comments? Assuming no. Our next board meeting will be August the 13th, and if there's no further business, we'll stand adjourned. Thank you for your time this morning.
Thank you
Mr.
all.
Chairman.
Have a great day.
Thank you.
Okay.